The novel agents have really made a huge impact in the last 10 years, especially the last 5 years. And Shaji Kumar from the Mayo Clinic has summarized the improvement in those years. And the information here shows the benefit in 5-year increments. And you can see here where we were in patients diagnosed between 2001 and 2005, then 2006 to 2010, and already patients that we're seeing and treating today probably have an outcome superior to that. In this middle cohort, we had a median survival of 7.3 years, which represented an improvement, particularly an improvement which we were very pleased to see for patients over the age of 65. But now we're probably looking at medians which are even superior to that. So we have many excellent treatments. We have 3 drug combinations, we have 2 drug combinations. I have to say, and I think we agree, that the 3 drug combinations, the results have been truly impressive. And when a patient is newly diagnosed these days, we can say the chance of having a response, a 50% improvement, is really very, very good. And that the higher depths of the response will occur more frequently. And even now, considering the possibility of an MRD negative status, maybe a quarter of patients could be getting down to this level, and it's something that we need to consider in more detail. If we look at the current options, I would say that on both sides of the Atlantic and around the world, we're looking at 2 types of therapy mostly: Velcade-based, Velcade Cytoxan and dexamethasone, Velcade Revlimid and dexamethasone. And at ASH this past year, there were some very interesting data updates showing excellent results with the CYBORD regimen, the Velcade Cytoxan dex, overall response rates, PFS data, overall survival data, really, really excellent. We were pleased to see the long-term follow-up with the CYBORD regimen out to the 5-year time point, and we saw that if we look at the good risk status patients based on the Mayo Clinic MSMART, good cytogenetic findings, overall survival 81% at 5 years for those standard risk patients. So really, really excellent results with the CYBORD. But we also now have another option coming along. What about Kyprolis instead of Velcade? And we had at ASH really outstanding data with the first look in small numbers of patients using Kyprolis with Revlimid. In fact, Ola Landgren's group's data with excellent response rates, early PFS data, and overall survival data. And then from the Torino group, Kyprolis Cytoxan index, also really excellent results. And so now we have a new choice, and how will we look at that? And so we have a first question. What do you guys recommend as your first choice in this frontline pre-transplant patient population, patients who you would intend to move forward with transplant? And so maybe I'll start with you, Antonio.
Certainly, I would agree with you. We have been improving the outcome very, very much in the last few years, and probably something more is coming with all the new agents that are, coming in the near future. For the pre-transplant, I would say, and I would completely agree with your previous message, we should certainly use a free drug combination. And I think the free drug combination has a backbone, the proteasome inhibitor, and is adding an alkylating agent that could be cyclophosphamide from one side, and from the other side, the IMiDs. Then with the second generation proteasome inhibitors, you might even improve this result using the carfilzomib compound. The other issue I would add probably is that the number of cycles is an important issue. And also before or after transplant, we should build up around the transplant setting a number of cycles that should not be less than 6 and maybe go up to 8. So I think that's
So you're saying we have been traditionally looking at 4 cycles probably? So you're saying that maybe we should look at a few more cycles?
It depends. Well, I would put around the transplant 8 cycles. So 4 and 4 or 6 and 2. But I think there is a need to increase the potency from that point of view to further improve the CR rate.
Okay, so either a pre-transplant and then a
Or
post-transplant consolidation to increase the number of cycles. So Ola, the one regimen there was the Kyprolis Revdex from your team. Is this something that looks so promising that this is where you're headed, or what do you think for a general recommendation?
You showed us the results from our presentation, and I think the data looks very promising in terms of responses. I can tell you beyond the numbers you showed us here that when we looked at the MRD level, from what we have seen in other studies where it went up to 30%, in this particular study we saw that virtually every patient that reached the CR was MRD negative. So maybe we're talking about 60 or more % being MRD negative in this study.
Wow.
So I think the depth of
Really
the response
high.
is extremely impressive. What we do not have, there are two major limitations with this study, is that we don't have the long-term follow-up. So what's the impact of these findings? And that, unfortunately, we can only wait
have to wait for that.
And also another limitation is obviously the size of the study. It's a phase 2 trial, so it's 45 patients. But I think the data are extremely promising. One other detail I would like to add is, as you know, this study, as a phase 2 trial, did not include autologous stem cell transplant. And still we see these impactful responses. So that's an interesting observation.
Right. And as these gentlemen know, and I'll mention to our audience, is that at this particular meeting there was a really intense discussion, I would say, unexpected a little bit for me, about the role of frontline transplant or delayed transplant. And so this is an important aspect that we need to think about. So maybe we can come around to that in just a moment. But
if I can ask,
yes,
is the length, how is important the duration of treatment from this point of view? Your CR, your excellent 50% MRD negativity is coming after 4, 6, 8 courses. So how much is important to prolong from this point of view the length of treatment?
So I agree with your argument where you talked about maybe adding more cycles. So that kind of feeds into this question. So how long did it take to reach this MRD negativity? And on average, it took about 5 to 6 cycles. So I think we're kind of leaving money on the table when we stop after 4 historically. Maybe you need to add 1 or 2 cycles if you're designing trials or if you're treating standard of care and take patients to transplant. I think stopping after 4 is probably too early, or if you add it afterwards.
Agree.
So that was what we learned from this study.
So Joe, I showed some data that's coming from the Mayo Clinic team, the CYBORD, and where you do actually have the long-term follow-up. What's your perspective?
No, sometimes it hurts me to agree with Antonio, but I actually agree with Antonio. No, I think actually it's very important.
Italy, so
I'm in Italy. Notice I'm growing a beard for Italy too.
You can disagree next time.
But no, I think to the 2 points I would make is one is that I agree wholeheartedly that at present it looks like a 3-drug combination is probably the way to go. That being said, using this cyclophosphamide instead of lenalidomide, potentially preserves it for later. And I think the long-term data that we have shows that this can be very effective in the long run, and perhaps a little less toxicity than using bortezomib and lenalidomide together, toxicity both to the wallet and to the patient in terms of clinical toxicity. And the second point that I would make is to agree with both of my colleagues here that the length is a very important issue. I think we were stuck in 4 because we used adriamycin in the past. And we didn't want to give more than 4 cycles. So I think a really key take-home message is that we're not bound anymore to 4, but we're not only bound to 4, but it doesn't necessarily have to be all before transplant. We've seen a number of studies now where even if you repeat the very same induction therapy that you've had before transplant as consolidation after, it can deepen that response. Now, whether or not you need the transplant is a big discussion in the future. I applaud Ola for looking at that topic and seeing how far we can get without transplant, but I think you're the champ until someone knocks you out. So I think transplant is still the champ for now, but I would encourage people to look, where are you immediately post-transplant? And maybe you can get more induction with CYBORD or whatever other regimen you've used to deepen that response.
Right, sounds good. So Stephen, any comments you'd like to add to this?
No, I'm very much in the CYBORD camp, working at Mayo Clinic as our preferred frontline therapy pre-transplant.
All right.
So why you would prefer the cyclo option instead of the lenalidomide option in terms of safety?
Well, it's as Joe said, it's preserve the Revlimid for maintenance or salvage therapy later. And also the cost of cyclophosphamide is considerably less than Revlimid.
If I could just add one more comment.
Yeah.
The only time I would be caught in the 4-cycle issue is if someone is receiving lenalidomide prior to transplant. We would encourage that the stem cells be collected after 4 and not beyond that, because it can be a little bit more difficult to collect stem cells if someone has received lenalidomide for more than 4 cycles.
I completely agree. That's an important observation.
Okay, good. So, pretty good consensus here.
We'll start with that.
Yes. All right. So